Hi everyone, thank you for joining us. We've got a few people sort of trickling in. Well, thank you so much for all the support. We've got a few emails, a few people interacting. So I just thought I'd quickly show you guys a little bit of collective minds radiology, what it is, because it can be a little bit like, oh, what does it actually mean? What does it do? So when you log into Collective Minds, what you end up seeing on the first page is the homepage, and you have loads of cases. You get hit with loads of cases, and these are cases involving neuro, MSK, vascular, chest. You can see it all. And it's quite interesting. You can kind of just go through the cases, have a look at the images, and see what interactions people are having with the cases themselves. So let's say, for example, you've got this one. You can click on it, and then it should eventually open up the actual case itself, and you'll be able to see some of the comments and things like that people, if they have replied and discussed it. And if you want to have a look at the images yourself, you can click on open review mode and have a look. Now, the point is to really teach and help one another, a bit of a global network. I think at the moment they're sitting about 9,000 people on this network. So lots of people from all over the world. I don't know if any of you guys managed to come see Collective Minds at UK.io, which was a conference at Liverpool, which happened on Monday, Tuesday, and today. They had a stand there. We had quite a few people showing interest to run their own teaching schemes, training schemes, courses, and that kind of thing as well. So yeah, do have a look. Getting an account is free, and at the very least, hopefully, you can all learn something from taking part in the community, and I'm there as well. And the great thing is that you can sort of at someone. So if you wanted to interact with me, you can just type in at Doc Lasker on the comments, and that just kind of alerts me by email saying that, oh, someone thought this could be an interesting case for you. And if you're anything like me, you quite like cases, you're quite looking at cases, you like getting a bit involved and having a bit of a conversation about what's going on and learning from one another. And it's really great because some people link in papers and things like that to do with the case that we're looking at. So it's kind of a nice sort of community teaching spirit that they've got going on. So anyway, today we are doing the third webinar where we'll just go through a few interesting cases. So far, I have very much concentrated on plain film x-rays, and I will start to do a few more different types of modalities as times go on. I keep it as chilled out and relaxed as possible. Oh, hi. Master, yeah, maybe. So basically, I try and keep it chilled out, this is not a teaching session. If you want teaching sessions, I do run teaching sessions through other companies. Mainly radiology seminars is where I do a lot of my teaching, and we use this Collective Minds as a way to facilitate that. So we do run the sort of courses through this, but this is meant to be laid back. We just have a chat. I'm not going to say I always get it right. I don't always get it right, and I'm more than happy to take on people's feedback during, after, whenever, really. If you think that you don't agree with something I say, it's the main thing is to, so hopefully, if you're a bit like me, a bit nerdy, and enjoy it. So I've uploaded a few cases. A few people like yourself in particular, who's in the chat right now, have thrown me a few cases to look at, and I've added that to this collection so that we can just kind of go through it and hopefully learn a few things. So what we'll do. If you want to say hi, please feel free to say hello in the chat, and while I decide to actually go through these cases. So I've made this collection over here, and what you can do is actually organize all your cases according to what you're up to. So on my particular area, because we run courses, we've got the sort of prostate course day, we've got the self-study day for one of the other courses they run, but for the monthly cases, I've made this. And it's quite good, it works perfectly, really, just like any other DICOM viewer. Obviously, depending on the screen, the resolution, that's kind of more on your side rather than our side, but the actual DICOM viewer is very, very capable, and you've got all the facilities there to be able to do the things that you need to. Right, so can I open the abdominal cases review? Just seeing, oh, really? Okay, not sure why. I'm gonna have to try and fix that later, because in truth, I was uploading it at the last minute again. There might be a situation where, what happens, sometimes there's a button that you press and it will say like make available for everyone. But so my apologies. What I'll do is I'll go back to it later, but if you don't mind just going through the cases with me live right now, and then just feel free to interact, comment, etc., and hopefully you still learn something. So this one hopefully is kind of straightforward. We've got a young patient come in with a bit of knee pain. How do I know it's young? what you've got to do is zoom in, and adult patients, they won't have these growth plates. And so what you can hopefully see here are a few growth plates sitting over here, going all the way along like so, another growth plate like there as well. And so this patient's got a few growth plates. They're fairly young. Not all, yeah, all the growth plates are visible, and they've got a bit of knee pain. And you can see that there is this region over here coming out, sort of a kind of quite well-defined protrusion coming out this way, like so, like so. Can everyone see that? And so when you see that,
I think someone in the chat was raising a hand. And obviously, if you've been to the previous webinars, I didn't do this in this introduction. But if you would like to talk, raise your hand, and I will unmute you. So if that was by mistake, you can take.
Okay, sure. So if you want to actually talk or get heard, then Sagittal here will enable you to talk if you want to during this webinar, and just have a bit of interaction that way. Or just feel free to add questions and answers, or put your things in the chat and we can talk. So okay, hopefully you can see. Oh, we've got someone called Liz. Oh, Liz, can we let Liz talk?
Yeah. So just need to unmute if she wants to talk.
Okay, so Liz,
maybe it was by mistake. I don't know.
Okay, so I'm going to keep talking in the meantime, and you should be able to unmute. What I'm doing, click on Ask to Unmute. So we've got this quite a well-defined lesion that is sitting over here, right? So first of all, the thing is, some of you may know what it is, but it's really important to sort of go through basics. And basics means, is it aggressive or is it non-aggressive? That's all we've got to figure out. Aggressive versus non-aggressive, that's all. And so when you've got something that's well-defined, that literally you can see I've got the pencil right now and I'm drawing it very, very well-defined all the way around it, then you're probably thinking that it's going to be a non-aggressive lesion. Also, when you look at the cortex, the bony cortex, this is kind of the board of the bone. It looks very, very well-defined. Doesn't look fuzzy, doesn't look like it's irregular. So that's another good thing. And then you look at the surrounding soft tissue and try and see whether there's any evidence of any edema or any soft tissue swelling. And actually you can see that leg sort of just keeps going down like this. It doesn't have a sort of outbowing at any point. It doesn't do this around this area. So you're looking at what looks like a non-aggressive lesion. Now, there are a few characteristics appearance with this, a non-aggressive, benign looking lesion. Now, remember I'm pointing out the growth plates sitting over here. This is pointing away from the growth plate. And that's kind of one of the most pathognomic features of what this actually is. So if it's pointing away from the growth plate, not towards the growth plate, then what you're looking at is something called an exostosis. An exostosis is a bony protrusion. It can happen in very young patients, and they usually kind of stay the same, and they point away. They're very well defined, and they're benign lesions. Now, the thing about exostosis is that they also have what is known as a cartilaginous cap, a little kind of hat, like a little baseball cap sitting on top. And depending on you don't want to have it you don't want it to be a very thick cartilaginous cap. If it goes beyond about 1.5 centimeters, then you've got to start worrying that it start to transform and start to cause a few issues, as in sarcomatous transformation. Now, the thing is, I've unfortunately seen in some x-ray where people have said that there's no cartilaginous cap. And that's not actually something you can't say on an x-ray, because x-rays are only able to see calcifications and high density material, but you can't really see cartilage, right? Unless you've got calcification within the cartilage, you can't measure a cartilaginous cap. And the only way to really measure a cartilaginous cap is by doing an ultrasound or doing an MRI scan. So generally speaking, you don't really have to do too much with these exostoses because they're benign. Yeah, by definition, being benign, i.e. non-aggressive, you're looking at something that doesn't need to be taken out, doesn't need to have anything grossly done to it. But there is a caveat that if it starts to get more painful over time, then it may be transforming into something else, like a chondrosarcoma. Basically, it's starting to have a sarcomatous transformation. It starts to become a tumor. And the way you can know that is by doing measurements or regular follow-ups of this if it starts to cause pain. And an MRI scan is also very useful to try and measure the cartilaginous cap. And obviously, you've got previous imaging to try and help you identify whether this thing is actually growing, because if it's growing even bigger than it used to, then you have to be worried. Now, the thing is, like, sometimes these things cause pain, but it's not because it becomes sarcomatous. It's actually because the fact that it's got mass effect onto the surrounding structures. Now, you can imagine that someone like here, so for this particular patient, they've got this lesion over here. Sometimes you can actually, well, and this particular person over here, you can also see a bit of a protrusion over here. And you can imagine the surrounding structures, maybe the MCL, that can start to cause a few issues. You've got bones, you've got musculature that's kind of tugging away all over it. And so you can end up having quite a lot of inflammation, even though it's not sarcomatous. you can get inflammation of the surrounding tissues just based on the way the person is moving the leg and the surrounding musculature, tendons, and that kind of thing within the region. So there are sort of local mass effects that can cause problems. Now, if we go back to this particular image, and if we just reset all, you may have spotted actually that's not the only lesion that is sitting there. You've also got another lesion that is sitting over here. And again, it's pointing away from the growth plate over here, and maybe a little bit of a protrusion sitting over here, again, which would be pointing away from the growth plate over there. So there's actually a condition called multiple hereditary exostosis. And so that just means that the patient will have multiple exostosis all over the body, not always over the body, always all over the body, but they've got multiple exostosis all over the place. And so they may end up getting a regular follow-up of these kind of lesions. So yeah, essentially this is what we're seeing is a single benign lesion, but actually it's not a single one. We've got 1, 2, possibly even 3, possibly even 4. We've got a few different lesions, which means that this patient's probably got a hereditary multiple exostosis. Essentially, yeah, exactly. Right. So let's go to the next case. So yeah, the main thing I wanted to illustrate is obviously benign versus aggressive versus non-aggressive. You can't really see benign. So aggressive versus non-aggressive, and also illustrate to you guys the point that these exostoses can actually get sarcomatous transformation, but just because sometimes people have pain, but it doesn't mean they've got sarcomatous transformation. Sometimes they've got pain because of a local mass effect that can happen in these lesions. Right, so this one, I'm going to just open up and you guys can have a quick look and see what you guys think. So yeah, so this patient's fallen on their outstretched hand, and they're coming in with a lot of pain. So those of you that are regular to my talks, I have talked about this kind of thing before. And so what you can see is when you've got adult patients, generally speaking, when you looking at the elbow and have had these traumatic events, the main place to look is going to be the radial head, and that will actually become more appropriate for a later case that someone else has brought in for me to look at this week or this month. And so the radial head is usually the place that you get injuries. And so when you've got injuries, you've got to take a really close look at the radial head in an adult patient. But when you've got a pediatric patient, it's not going to be the radial head per se. You're going to be looking at the supracondylar region. Now, the reason I think that the radial head gets affected more than anywhere else in adult patients is that when the patient falls over, what ends up happening is you get the forces going right straight through the radius. So at this end, the largest part of the wrist is going to be the radius. So that absorbs a lot of the weight, and that goes all the way through, translated all the way through to the elbow, and then comes across to where it actually becomes thinner and thinner and thinner. And then all that force, brute force, get hit right on the end like a hammer, hits in the capitellum, and you get what is known as a fracture of the radial neck or the radial head. And so in this particular occasion, what you can see, hopefully, is a fracture of that radial head. If we draw a line like so, you can see a radial lucency like this, radial lucency like this, and it goes along like so. So what's important about this one is that there's intra-articular surface involvement. So we don't say the tip of the radial head. We just say there's a radial head fracture with intra-articular surface involvement as well. So obviously, you know, being a radiologist and someone who's working in healthcare, you also do want to make sure that you do have a look at the capitellum. Make sure there's no evidence of any fractures there. Sometimes you can get a secondary osteochondral defect or fracture because of the impact that happens when that radial head hits that capitellum. Also, the sagittal views, let's have a look and just see to confirm what we're thinking. You can see on the sort of the more sagittal views of the elbow, that radial head fracture is not as obvious. But in this view, you can actually see a lot of that joint effusion. You can see a joint effusion there, and you can see this hyperdense material sitting over there. So it's probably a bit of blood that's kind of extruded out of the fracture, and you can get to see the sort of bowing of the joint capsule over there. Now, again, for those of you that have kept up with my talk before, sometimes you may have a fracture that is just slightly outside of the joint capsule, maybe in the radial neck. So you get a fracture over here, and because it's outside the joint capsule does not have any evidence of any effusion, right? So you actually have no effusion, no posterior fat pad elevation, but what you end up having is a fracture of the radial neck, but it's just slightly outside of that joint capsule, meaning it doesn't get involved. Now, a bit of a pro tip as well is that when you do get extensive injuries where someone's fallen on their outstretched hand, you also want to have a look at that process over here, the conoid process sitting over here. You want to make sure there's no evidence of a fracture, because if you have a fracture of this, that means that there is the ability of that whole elbow to slip out, and you actually get a very unstable joint. So this happens a lot actually, where someone has something called satisfaction of search. It's a phrase that radiologists use, where you see an abnormality, you think, yeah, I've done it, I'm going to move on, and then you move on. But actually, a lot of the job for radiologists is just to look for the next finding, because what they say, I guess, is that the most commonly missed fracture is going to be the second fracture, because everyone kind of gets all happy you've seen the first fracture, but it's the second fracture that gets missed. And that's the thing that you need to be looking for with these things. But in this particular occasion, we don't have a second fracture. What we have is that only primary fracture sitting over here, which is going to be that radial head. Right, and obviously we've got that joint fusion as well. So yeah, I'm sorry that the abdominal pain ones haven't, some of you aren't able to open the abdominal pain ones, but I'm going to open it now. It may take a couple of seconds while I do that, and if that's going to be the case, I'm going to open a couple more in the background so that we don't have any delays between cases. Okay, that's taking a while to load up.
It's Imran, it's recommend that you can only open one at a time, one viewer at a time, so you can't tab like that.
Okay, one viewer at a time. Okay, fine. Okay, so let's have a look at this one. So I want to look at the plain film first. So let's go for the plain film. And so most of the time when you're doing this plain film x-ray, obviously feel free to throw in your answers. Young person with abdominal pain. Oh yeah, so someone said Ollie's disease. Yeah, you're right. Okay, good, with that previous case. Okay, so with this one, we have got someone who's come in with abdominal pain. And so usually when you are, yeah, well done. So when you are looking at abdominal films, first of all, you do want to look at the bowel gas pattern. You want to see whether there's any dilatation of the bowel. And when we say dilatation of the bowel, you're looking at air-filled bowel dilatation, because if it was fluid-filled, you won't be able to see that. So when you're reporting no evidence of obstruction, if you are reporting radiographer or a radiologist or a registrar, what I encourage you to do is to use the phrase no air-filled bowel obstruction is identified, because you cannot rule out where there's fluid-filled bowel obstruction. Because I have plenty of cases where it looks completely normal on the abdominal film, you do the CT and there's multiple loops of dilated small bowel all over the place. But in this particular situation, you can actually see multiple loops of small bowel and large bowel. The large bowel is sitting all around like so on the outside, and in the central area you're going to have the small bowel, and none of it looks particularly dilated, but a few people have already spotted, well done, that there seems to be what looks like a mass effect. Everything's kind of pushed away, right? So what should be happening is that you've got all the large bowel on the outside, and in the middle you just got all this small bowel. But in this particular image, you can feel like there is a bit of a mass effect, kind of everything pushing upwards like so. So at the very least, you should be able to say that there seems to be what looks like a bit of a mass coming from somewhere, and more likely to be coming from what looks like the right side of the abdomen. Obviously, you've got other shadows to be looking at. You've got your liver, you've got your spleen over here, you've got your gallbladder over here, you've got your kidneys over here. And then you've got urinary bladder over here quite centrally. But this mass appears to be slightly different. It doesn't seem to be coming from those kind of approximate areas that you'd expect the normal anatomy to be. So if your normal anatomy doesn't conform to what this lesion is, then you've got to start thinking about what else this could be. So something in the pelvis. This patient is a female patient, which I probably should have mentioned. So this could either be a uterine lesion or it could be a uterine lesion. It could be an adnexal lesion, i.e. ovaries. And obviously being in the right iliac fossa, it could also be something like an appendix that could be coming up. Quite unusual for an appendix to be this big, but I suppose if you do have an appendiceal tumor, that kind of thing, then yes, you could be looking at an appendiceal lesion. Now, for those of you that are quite eagle-eyed, you can see that yes, there is, well done, there is what looks like a calcification sitting within there. So when you've got calcification sitting within what looks like a pelvic mass, again, yeah, you're right. Someone may say, well, you know, you could get fecalith material. Fecalith material sitting within the appendix can get calcified, so you can get an appendicitis or an appendix abnormality that has got calcification with it. Other things that can have calcifications, obviously you can get calcifications of lymph nodes, all right? That could be previous TB, it could be ongoing sarcoidosis, it could be, I think you can get calcified lymph nodes in when someone has non-pasteurized milk as well over time, and obviously previous infection. And the other thing that can happen is you get desmoid tumors as well. So desmoid tumors where you get sort of calcification, so you get desmoplastic reaction, and then you get calcification of some of the mesentery, and then ends up getting this kind of clumpy calcification. Some of the bowel gets pulled towards it. And when you get bowel pulls towards something, usually you would end up getting bowel obstruction. In this situation, yes, we do have a calcification, but we don't have a anything else, nothing looking like anything being pulled towards it as well. So at the moment, all we have is what looks like a mass, and we also look what looks like we've got a calcified density. Not much more we can say beyond that, and a few people have thrown a few differentials. Maybe you've jumped onto the CT, which is fine, which is great. If you haven't, you've got some good differentials there, so yeah, that's good. Iliac bone infarct, yeah, I guess it could be. I mean, you could say that, but then in the absence, if you had just had that sitting by itself and nothing else going on, then yeah, you may say to yourself, this could be an iliac bone infarct. Oh, one more thing it could be is a renal calculus, but renal calculi tend to be in line with the ureter, which yeah, you could say it could be, but it doesn't seem, it's not usually so clumpy and circular. So it's very, very circular in appearance, whereas renal calculi don't tend to be as big as this, and if they are, they're normally kind of thin and cylindrical, not so clumpy like this as well. So yes, at the moment so when you've got a lesion like this with an associated what looks like a mass effect coming from the pelvis, there's only really one thing that it could be, but I'm going to go to the CT to show you. So let's go from the very, very top. What I'm going to do is just download that in the background. So for those who don't use Collector Minds, if you are using it, you can actually use the little cloud button sitting here to sort of speed things up, and hopefully things will be a bit smoother. So abdominal pain can happen for a few different reasons in any patient. Obviously, cholecystitis could be one, but we did see something abnormal in the lower abdomen. But just to show you, this is the gallbladder, and that looks completely normal. What phase is this? This is a portovenous phase because the aorta doesn't look as bright as the vertebra. It looks almost the same kind of density as the portovenous system. And actually, the portovenous system over here looks slightly brighter. So this is more likely to be a portovenous image. And coming through, this one does have a few calculi. Can you see that? If we kind of scroll through, you can see the circular density sitting over here. And, when you actually, this is quite a good point. So, you can't see that calculus on the X-ray because actually it's not a calcified calculus, but on CT, you can see that calculus. But even on CT, sometimes you don't see that calculus because it's not actually that heavily calcified. Sometimes you get cholesterol calculi, which are not visible on CT and on X-ray. Right, the other thing that can be causing abdominal pain is going to be the pancreas, but the pancreas, this fluffy looking thing sitting right down the center of the abdomen, looks completely normal as well. So that doesn't look like anything to worry about. And remember, we're saying, could this be a renal calculus? So we're looking to see whether there's any evidence of any hydronephrosis, which would look like Mickey Mouse hands, but this doesn't look like a Mickey Mouse hand on either side. Both kidneys actually look pretty normal. And the ureter, which is sitting over here, looks fairly normal as we scroll all the way down. So if we kind of scroll all the way down, you can hopefully see that big mass. But the actual urinary bladder and the ureters actually look normal on both sides. But now what we see is this huge looking mass sitting within this region, right? So we've got a huge mass sitting within that region. And as someone said, where there's fat within that liver, I wouldn't call fat on this liver based on this image. Obviously, this is a non-contrast study, but as far as I've read, if there's anything less than 40 Hounsfield units, then you've got to go with steatosis. And if you were to measure that, it wouldn't be a less than 40. And generally speaking, you'd usually want to do a non-contrast study if you're going to be investigating fat infiltration. The gallbladder calculus is there, but it's not causing any abnormalities or any sort of compromise at this present time. So yeah, so well done. So yes, this is a female patient. And you can see that there is a uterus sitting over here, and you can see this very, very large lesion sitting over here. But what you want to do is sort of make sure that you are 100%, you know exactly what this lesion is. And so you've got to kind of make sure you go through this case properly. So you could say, look, I think it's teratoma, which you're fine, you may be right, but how do I 100% know that this is not an appendiceal lesion? And the only way to really do that is to go through the bowel, right? So I always say the constants are going to be the descending and the ascending colon on either side. So this is the descending colon. They're pretty much always going to be there. They don't really move. The sigmoid colon can go for a walk. The cecal pole can go for a walk. The transverse colon can go up and down all over the place. But generally speaking, the descending and the ascending colon on both sides of the abdomen stay the same. So if you're ever lost, go for those sides. So on this particular occasion, I'm going to go for the descending colon. You can see the bowel going right across the front like so. Now we're at the hepatic flexure. We're going all the way down, all the way down, all the way down. And you can see that this is a cecal pole sitting over here, but we can't really see a connection between the cecal pole and this lesion, right? And then you can see this kind of area, this tubular structure coming from this area over here and finishing. Can you see that? That one there, coming this way, this way, this way, this way. It feels like it finishes, doesn't go anywhere else. So that could be the appendix. But again, the point is we can't see a connection between the bowel and this lesion that is sitting over here. So that's kind of, again, yeah, saying, okay, we don't think this is a bowel lesion. I don't think this is appendicitis. I reckon this is something else. And people have already said, so this looks like an adnexal lesion and a varying lesion. But what kind of lesion is it? When you look at this, you've got a few varying densities sitting within this lesion. You've got some sort of, you've got a bit of a higher density, you've got a bit of lower density sitting over here, almost fat-like, you know, when you're looking at the two. But more importantly, you've got these sort of hyper-dense materials sitting over here. If we go to the bone windows, which is going to be the clincher, hopefully, you can see that that doesn't look, that looks like a tooth. And there's only one reason anyone would have a tooth within the abdomen, unless they swallowed one. It's because, exactly right, you can see that looks like a tooth, doesn't it, sitting within the abdomen. Only one reason, exactly right, well done, a teratoma. So yeah, you can say, well done, you've got teratoma. Is that all we should be worried about? Well, the thing is, people can have teratomas and have no symptoms whatsoever. But if you've got a patient that's got symptoms and they've got a teratoma, and actually when you look in this region, look at the fat that is sitting over here. Can you see that? Compared to the fat that's sitting over here, it looks like there's a bit of inflammation going on. This doesn't look quite right. And a young patient has come in with what looks like a large teratoma and a bit of fat stranded located within the pelvis. You have to be worried that this patient may actually have something known as a torsion. So what can happen is you've got the fallopian tube and it can actually become twisted on itself, start to cause issues. And so this patient needs to go to the gynecology team as soon as possible, because they're going to be clearly in trouble. There's going to be some compromise, and obviously long-term implications could be death, and obviously less than death could be infertility as a result of significant torsion. So yeah, that could be the cause of pain. So yes, teratomas, you can find them incidentally, but in a context of someone who's got pain, you've got to take it a little bit more seriously and send them off to be seen by the surgeons. Right, so we're going to be looking at this case over here. So while it just loads up, I am going to just download that one, make this full screen. We have got another abdo-pelvis, youngish patient. Feel free to throw in what you think could be going on. So with this one, we've got a young patient. Don't get put off by what these things are. They're probably just artifact from this patient. Yeah, exactly, 2-ring artifacts. It could be a belt. And I actually do remember when I was a young gun back in the day, there was someone with abdominal pain and we did the x-ray and I got really stressed out because it looked like they swallowed lots of metallic artifact, and I ran in to quickly examine them and it turned out it was just the belt. So there you go. So this could be just something artifact from it could be just artifact from some of the patients wearing. But when we go back to sort of basics of x-rays, we're looking at the bowel pattern in particular. So within the central abdomen, you're going to get a whole lot of small bowel. Along the outside of the abdomen, you're going to have the large bowel. And this large bowel doesn't look quite right. Exactly. So well done. A few people have thrown in their answers. Well done. So what you can see is that this looks like the transverse colon, but you don't have that sort of normal kind of cloudy appearance. You don't have what is known as haustra, these lines that go incompletely across anywhere. This looks almost like a cucumber or like a tube, doesn't it? Like a lead pipe, someone might say. It just looks very, very featureless. You see, I'm throwing all these lines that are kind of, these are the lines that people want to hear when you're doing the radiology exams or when you're doing your exams or even your report. As soon as you say certain phrases, it means certain things. And in this particular situation, when you say featureless, lead pipe appearance to the large bowel, you're kind of only really saying one thing. You think about inflammatory bowel disease. So this patient's come in with abdominal pain and we've done the CT scan. So why would someone with abdominal pain, and let's say they've had that x-ray, and they've always looked like that. So if they've always had this problem, why on earth are we doing a CT scan? It's because when someone has got inflammatory bowel disease, they're going to be predisposed to certain things. And one of the things that they can have is something called toxic megacolon, which is something that kind of acts like a bit of an obstruction. You could also, exactly, well done. So they're going to have Crohn's, but I'm saying that if someone's got Crohn's, why would you do a CT scan? And the reason is that they're also predisposed to perforations, so they could get perforations. The inflammation can result in fistula, so connection between bowel. So that can, and you can get fistula between the bowel and the skin, between bowel and the uterus. You can just get connections between places as a result of the multiple inflammations that can happen, which CT is very good at looking for. And yeah, so I mean, and then obviously someone who's got Crohn's disease, ulcerative colitis, they're going to have a larger proportion of those kind of patients are going to have the possibility of having a malignancy. So when you get patients who've got known Crohn's disease or any sort of inflammatory bowel disease, I tend to have a bit of a low threshold to do a CT scan on them. So again, if we start kind of from basics, what kind of scan is this? This is not on our aortic face, not arterial face, because that aorta sitting there is not as bright as the bone on the soft tissue window. And as we go to the portovenous system, sitting over here, the portovenous system actually looks slightly brighter than the aorta, so therefore there's going to be a portovenous system image. Gallbladder looks okay, that's a gallbladder there, no evidence of any gallstones. Pancreas looks okay, that's the pancreas, that fluffy looking thing sitting down the middle. And if we look at the kidneys, they all look okay as well. So when you're looking at abdominal pain, those are the kind of the main things you want to be looking for. And then after that, you want to be looking at the bowel. And then you kind of got to do a little bit of legwork to look at the bowel. So if we look at, say, as soon as we start on this bowel, hopefully people can see this, yeah? As soon as you look at that bowel, you can see that the bowel wall looks a little bit hyper-enhancing, looks a bit strandy along the outside. And as you kind of scroll through, that's a sigmoid colon, and you go to my constants, which is going to be the ascending and the descending colon. And in this particular situation, we're looking at the descending colon. You can see it doesn't quite look the same as the bowel on the other side. And if you look at the other side, if you compare the two, look, bowel compared to bowel, yeah? Bowel compared to bowel on either side, this looks very much more collapsed, slightly thickened bowel walls, and this one kind of has a cloudy appearance, like, you know, the cumulonimbus clouds. I can't remember what they are, sorry, but you can see this doesn't have that appearance, and especially when you come up to the transverse colon, it just looks like a cylindrical pipe, right? And you can see that going along like so. It doesn't have very many features. It looks quite inflamed, and you're going along. It looks more and more kind of inflamed as you go along to this way, all the way along here, and then it starts to have a more of a normal appearance within this region. So someone's written edema in a sigmoid pattern. I don't usually use that phrase because I guess if you're saying that it's only the sigmoid colon that's inflamed, then you may be saying something like colitis focused to the sigmoid colon, or what people may interpret as, is there diverticulitis? Is there diverticular disease? Is that what's going on? This is more kind of you know, uniform inflammation. Now, if you say something like a segmental pattern, then you're going to be start thinking about is this conforming to vascular territories, right? So we've got a few vessels that supply the bowel. So you've got your left colic, you've got your middle colic arteries that supply the transverse colon essentially, and you've got your right colic arteries as well that supply some of the terminalium and the ascending colon. So if your inflammation only affects certain segments of bowel, then you've got to start worrying about whether there's ischemia, because what you're saying is that the blood flow to those segments of bowel is being affected. But when you've got what looks like quite uniform inflammation, the sigmoid colon going up the sort of down or down the descending colon and upon the transverse colon, you're looking at multiple vascular territories here. And so when you've got multiple vascular territories, you're less likely to be looking at ischemia. And so I wouldn't go with segmental inflammation. I'd just be going for sort of a uniform inflammation involving, and just describe it, sigmoid colon, descending colon, transverse colon, some loss of the normal features on CT as well. But the key things you want to take away from this is that there's no evidence of any perforation, collection, or fistula based on the CT images. And so this would more likely be in keeping with underlying inflammatory bowel disease, such as Crohn's disease. And remember, Crohn's disease can have skip lesions, so it doesn't just be inflamed on the large bowel, it could be inflammation of the small bowel as well. So you do have to have a look at the small bowel and just make sure there's no evidence of any focal inflammatory regions within the small bowel as well. Obviously, ulcerative colitis is going to be inflammation of the colon, the large bowel, and won't be affecting the small bowel per se. Right, so hopefully that was an interesting one. So hopefully, I mean, for those of you that are sort of kind of coming to these talks regularly, you can see that I'm starting to introduce a bit of cross-sectional imaging as we go through them, because the previous ones we were just kind of hammering a few x-rays, and to make things easier or more interesting, I'm going to start putting a few small CTs and working through it with everyone here. Okay, so this one, let's have a look at the CT scan. We've got the CT scan here and this x-ray, and patient again has come in with abdominal pain. And so main thing is to look at the bowel gas pattern. And yeah, so someone has said that they can see what looks like dilatation, and they said it's jejunum, it may be jejunum, it may be small bowel. We don't know. Yes, it's in the upper abdomen, so you can infer that it's going to be the sort of proximal bowel. But the main thing is that you can actually see what looks like dilated areas of bowel over here. So hopefully everyone can see that. That bowel there, yeah, you can see that has got these lines going right across, yeah. So when it goes right across like so, this is going to be in keeping with small bowel, and these lines are known as valvular conniventes, not haustra, valvular conniventes. Haustra is going to be in keeping with large bowel, and valvular conniventes is going to be keeping with small bowel. So definitely looking at something that's going on within the small bowel. Now, you have to remember that, yes, if you have some sort of obstruction going on in the large bowel, you can get concurrent small bowel obstruction. But in this particular situation, the large bowel sitting on the outside actually looks okay. What you do have is what looks like, it does look like there is just dilatation of the small bowel. And in the context of pain, what you can see is, you'd be worried. So you've got to do the CT scan. So someone has said, is there an infarct within the bone? And you know what, we've got, what one of my consultants said is truth data. We've got the truth waiting for us to look at all together right now, and we'll be able to find out whether you think that there is a bone infarct. And the reason why someone said bone infarct is that lesion that is sitting over here. And it doesn't look very well defined, doesn't look very clumpy, it looks kind of ill-defined on the edges, so it may very well be an osseous abnormality rather than an abnormality sitting within the abdominal cavity or pelvic cavity. But now when you're scrolling through this one, what you can see is that as you come up to here, you can see some air sitting within the biliary tree. You can see that sitting over here. Just draw that out for you. So air, how do I know it's air? Because the lungs have got air, the outside of the world has air, and this area has got air, right? And that's air within the biliary tree. I know it's not within the portal system, the portal veins, because you can see that the portal vein is sitting right next to it. So that's good. So it's going to be air within the biliary system. What phase of imaging is this? Again, the portal vein seems slightly brighter than the aorta. So there's going to be a portal venous system image. And you can see that there is the gallbladder, which is sitting over here, right? So this is one of the check things. Now it looks like the gallbladder is sitting there, but there's also air sitting within that gallbladder, and it almost connects to what looks like bowel sitting within that region. So hopefully that will, ring a few alarm bells. Okay, so for those of you that don't know what it is, don't worry, I'm going to work my way through it. We've got an NG tube sitting over here, right over here. That's normal, that's fine. Small hiatal hernia, no complication there. The kidney's got a cyst there sitting over here, nothing to worry about, and no evidence of any renal tract obstruction. The pancreas is sitting over here. That looks okay, nothing to worry about. Spleen looks okay. But then as we scroll through, hopefully you can see is what we saw on the X-ray. We saw multiple loops of dilated bowel. Small bowel, in fact, and you can actually see that the valvular conniventes do go all the way across, and there's actually some air-filled and some fluid-filled dilated bowel sitting within this region over here. So someone said that that kind of calcified lesion could be a bone infarct, right? It may be. Let's just work with that for the time being. Let's go from the beginning. I know it's a bit, I always like to go through basics, and genuinely, this is what I do when I'm reporting. I do go through it every single time, go through the bowel, go through the bowel. So you can see the little outpouchings over here. That looks like diverticular, and none of them look particularly inflamed. You're going along the sigmoid colon, coming up this way, coming up this way. Now we're at my constants. We're looking at the descending colon. Then we're going up to the splenic flexure, going right across the front like so, like all the way across. That's the transverse colon. Then you're at my next constant. And can you see, look at the fat that's over here compared to the fat that's over there, which is very, very strandy in that right upper quadrant. Something's happening that's not quite normal. And you come all the way down to the cecal pole. And actually you can see what looks like a little bit of fat sitting with the cecal pole. And that is where the terminal ileum will be coming out of. And these are like little lips, and that's what the ileocecal valve is made up of. And as you come down further, you can see, I think you can see a blind ending loop. See that thing there? That looks like a blind ending loop that goes this way, this way, this way, all the way anterior, and then stops. And so that is most likely, it's quite a long appendix sitting over here. See that? It kind of goes around like so, curls this way, comes all the way back up, all the way back up, all the way back up into the cecal pole. So we know it's not appendix, that's not the issue. We've got inflammation located within the right upper abdomen. And then the thing is, you can see the terminal ileum. If we go back to the fatty lips, they look okay. It doesn't look particularly dilated, that terminal ileum, and you can probably follow all the way around like so. But the main thing is what you can see is this dilated bowel. If you kind of keep your eyes over this region over here, you can now see what looks like a hyperdense spherical lesion that is sitting over in that left lower abdomen. So yeah, someone's saying, is it interception? Is it not? I mean, so interception is where you get telescoping of the bowel onto one another like so. This could be, but actually when you look at these coronal images, you can see that there is what looks like the spherical density sitting located within the intraluminal cavity, right? And there doesn't seem to be any telescoping, no overlapping of the bowel. And so this looks a lot like that gallstone that we saw earlier. Do you remember that gallstone we saw on the gallbladder on that previous case? That looks like a gallstone, but it's sitting all the way in the small bowel. And what's actually happened here is that this person did have a gallstone. It's eroded its way through into the small bowel. Sometimes it's the duodenum that it kind of erodes into. Maybe there's a connection there, and it kind of goes on a bit of a journey, goes for a bit of a walk, and eventually it can't go any further. And then you get a gallstone ileus. So then it kind of gets stuck and it's like, all right, mate, I don't know where to go now. And then the rest of the bowel behind it goes, you know, what are you doing here? And the whole thing gets dilated, gets really angry, and you end up getting something called gallstone ileus. So let's have a look at the bone windows, because sometimes it is quite good just to see. Someone said that they felt as though they saw a bony infarct, and because we have what we call the truth data, yes, can you see that? Yeah, there is what looks like a bone island, a bit of a bone infarct sitting there. That also correlates with what someone was talking about a bit earlier. And you can see that, right? Now you can see that there is that bone island sitting there, but not that's actually not related to anything else that's going on. So in conclusion, with this particular case, what we have is inflammation located within the right upper abdomen. We can see air within the biliary tree. We can see air within the gallbladder, multiple loops of dilated small bowel, and what looks like a well-defined spherical laminated gallstone located within the left lower abdomen, resulting in what is known as gallstone ileus. So yeah, hopefully that is an interesting case. And sometimes it's quite good to look back and see whether you can find the calculus. And I don't think you can really 100% say you can see the calculus on this particular case, but I have seen ones where you can literally see the calculus sitting right there. Right, so we have been through this one. Let's go through a chest x-ray to kind of ease up a bit on the cross-sectional imaging, because cross-sectional imaging can be a little bit involved, can't it? All right, so we're looking at this chest x-ray. Okay, looks like it could be normal. We know it's fairly young. Sometimes you can tell that they're fairly young because you don't have calcifications of the more sort of chondral aspects of the intestinal bezoar could be differential too. Bezoar, yeah, I suppose so. You'd have to have a history of someone swallowing a lot of things, but when it's spherical, without the previous case, when it's spherical and you've got that, you can't use that differential because we've got almost a slam dunk diagnosis, because you've got air within the biliary tree, air within the gallbladder, and that spherical lesion. And so when you balance it, it can't really be anything else. It's not going to be bezoar in that particular situation, not when you've got so many other findings that are kind of pushing you towards gallstone ileus. So this one is a youngest patient, and they have got this chest x-ray. They've come in and they are fairly young, because you don't really see much in the way of calcifications in the sort of sternal area. So if we look at this, at first it may look like it's okay, but my check area is always going to be the costophrenic angles. Costophrenic angles look like so. These areas here look very, very sharp. They look fine. Lung apices, they look okay. And a bit of a pro tip would be not to just take it at that value. You want to zoom in and also pan and have a look at that lung apex and make sure there's no sort of pneumothorax, and the lung markings going all the way through to the edges, and they all look okay from what I can see. Right, so the lung apices look okay, that's good. And then you want to look under the hemidiaphragms. So look under the hemidiaphragms and make sure there's no air under the hemidiaphragms. Make sure that you cannot see any air sort of seeping up here. Sometimes air that goes all the way along like so shouldn't be there. You should have no interface between these structures. And if you do, then you're looking at a continuous diaphragm sign, which we don't see here, which is great. So everything looks okay so far. And then look behind the heart. We don't see any abnormalities, no lesion behind the heart. We don't see any sort of sail sign. Sometimes you get tenting of the diaphragm to tell you that there's been some loss of lung volume sitting within that hemithorax, which we don't see. Sometimes you get elevation of the hilar, but the patient's slightly rotated, so it's not quite equidistant between the two, maybe slightly angled when they took the x-ray, but it doesn't look like there's any particular loss of lung volume. And the distance between the ribs, they all look okay as well. So that's another way to tell whether there's any loss of lung volume. Now, when you look at this, this should be very, very sharply contoured. There shouldn't be any sort of particular soft tissue density here, but someone has quite rightly said that there is what looks like the sort of globular looking appearance sitting over here, and actually you've got your aortic knuckle sitting over here, but you've actually got more soft tissue sitting over here. So what could be causing that? It's going to be adenopathy. So at this point, you can't really say much else. You can't say much else. It could be sarcoidosis, it could be lymphoma, it could be tuberculosis. Now, in this particular occasion, it turned out to be tuberculosis that was the cause of it, but it could be any of those other things. Now, with sarcoid, you may have sort of reticulous or net-like densities that are going along like so, but they'll be very, very nodular, tiny little nodules sitting along there as well. That will tell you that it could be sarcoidosis along with the lymph nodes. You can get calcification around the lymph nodes as well, which will tell you sarcoidosis as well. But if this patient's coming with fever, which is what they came in with, then you are probably looking at something like infection, or it could be lymphoma. Lymphoma can cause that kind of thing as well. Okay, so hopefully that was, so here we go. So this was a case someone threw, and I think they tagged me, and I think you are here today. So thank you for getting involved and getting me involved as well. I always like having a look at an X-ray. So this patient, they have got a X-ray of the hand. And then what can happen sometimes is that patients will get an X-ray of the hand, mainly because they've fallen over, they've got pain within their scaphoid, and they're worried about a scaphoid fracture. And so when we look at this one, hopefully you can see that in the region of the scaphoid, that boat-shaped the boat-shaped bone of the wrist, this thing over here, there is what looks like a very well-defined spherical lesion sitting over here. Now, this has got a very exactly well done. It's very well defined. Literally, I can get a pen, I can draw it for you. I'm not saying that, oh, it could be extending over this way. You can't see bony expansion anywhere. So there's no bony expansion anywhere at all. When you look closely, there's no cortical reaction as well. So there's no kind of reactive process going here. No soft tissue reaction. You don't see any sort of bump over here as well. So what you're looking at is, you can't say benign, you can't say aggressive. You've got to go, you can't say a benign versus malignant. You can say aggressive versus non-aggressive. So this is a non-aggressive lesion based on the imaging findings that we have. And actually, I've seen these described as intraosseous ganglion cysts. And it's not just here you'll see these. You can see them on the shoulders, you can see them in the knee, the tibia mainly, actually, where you see them. Now, you're not usually that bothered, but you have to imagine that you've got cystic transformation of the intraosseous structures, and that can actually result in slight weakness. So they can end up getting pathological fractures of these. So sometimes you do get fractures going through these lesions as well. So it may be the case that they're going to fracture anyway, given the traumatic event that they had, but sometimes it can actually act as a bit of a catalyst. You get a fracture there, and the whole thing fractures all the way across, because they've got a kind of what is otherwise a non-aggressive lesion, but resulting in some architectural weakness. Right, so yeah, thank you for that one. I do appreciate having a look at this one. And again, yeah, someone tagged me on this one. I think the last three are tags, which is great. I really do appreciate these. So this one, I mean, I had a look at the comments as well, so I kind of know what someone has said it is. But when you see this, hopefully you can see that there is something clearly abnormal located within the right lower abdomen. And so some people may say that, oh, well, you know, this could be a collapse of the lung. It could be a collapse of the lung, yeah, maybe, I suppose so, but it doesn't have the other findings of a collapse of the lung. When you're saying collapse of the lung, you've got to think, okay, is it tenting of the diaphragm, hemidiaphragm? Does that look tented? Not really. That looks very, very flat. But yeah, you do have a bit of blunting of that costophrenic angle. Look at that costophrenic angle compared to that one. So that is some fluid within that right hemithorax. But when you've got this lesion sitting over here, also the things that don't tell you that there's going to be collapse or anything like that is that the hilar look very, very central. It doesn't look like it's particularly raised. There's no crowding of the ribs. So the ribs actually look pretty equidistant and almost identical to the other side as well. So we're not looking at loss of volume here. So what we're looking at is actually some sort of added volume, something added here. So when you look at this lesion, so if this is like any other, what you can see is that it kind of becomes a bit ill-defined as you get to the outside of it. So when you've got an ill-defined aspect to a lesion on the lateral aspect of the lesion, then you're probably looking at something that's going to be pleurally based. That's kind of one of the telltale signs of something that's pleurally based rather than intraparenchymal. And you'll see this like with pleural thickening, with fluid. Sometimes you get loculated fluid within the pleura, and that can result in sort of ill-defined lateral border. Ill-defined lateral border is a good way to know that this is more likely to be pleurally based rather than being intraparenchymal. Now, the other thing that people may wonder is this going to be a neurogenic lesion? A neurogenic lesion would be coming from the actual sort of from the exiting nerve root foramen. So you can actually see that there's really not much in the way of involvement of the interneural foramen. There's no widening, no scalloping of the vertebra within that region. So less likely, based on these findings, someone's very helpfully done a lateral view. And again, you can see the sort of fluid looking area sitting over here. And you've got what looks like a very well-defined lesion located in the posterior aspect. So when you've got a lesion that is sitting like this, you've got that sort of ill-defined lateral border, you've got a bit of fluid located with a costophrenic angle. I would be going for where this is more likely to be a plurally based lesion. And when you say it's a plurally based lesion, therefore this would be, this could be a loculated effusion. You can get effusion that are loculated. Sometimes you get fluid sitting within the oblique fissure. And I think in this particular occasion, they said this person was turning up with fevers. So when you've got fevers, you've got to be worried that, okay, fine, you've got fevers, then this could be something like an empyema. Most likely you're going to end up doing cross-sectional imaging. The reason you want to do cross-sectional imaging as someone who's got fevers is just to know whether they've got a potential, how big is this loculation, and whether you can actually think about doing a sample, and you could do an ultrasound first if you really want to. But generally speaking, we'll just go straight for CT, see how big this is, look at how we could possibly get a sample from this and send it to the labs for finding out, what their patient could be, what antibiotics the patient could be susceptible to. So yeah, thank you very much for someone tagging me on that one. Please remember that when we go through these cases, I'm not giving you diagnostic, I'm not trying to give diagnosis. This whole point in this is meant to be educational rather than me giving you diagnostic, and just my opinion. I'm not saying I'm always right, and I'm more than happy for you guys to disagree, message me via the platform as well. So the final case, we're doing pretty well. Final case here is what looks like well, hopefully you can see it's a fracture, isn't it? Going right down that mid shaft of that humerus. Young patient, you can see they've got growth plates, and you can see a fracture going through there, can't you? All the way through like so. So now when you zoom in, that looks like it could be a pathological fracture. And when I say pathological fracture, I'm not saying that there's an aggressive lesion that's resulted in it. Pathological fractures can happen because of a weakness in the bone. And this looks like there's a weakness in the bone because there is what looks like a lesion sitting within the region over here. And actually, when you look at this, I can draw this very, very nicely, very well defined. There's a little bit of scalloping of the internal cortex over here, and you can see that there is a bit of what looks like ground glass changes sitting within this lesion over here. So I'd be concerned that this could be fibrous dysplasia, resulting in weakness of that mid shaft. They've fallen over and end up getting a fracture. So this is a pathological fracture through what was a non-aggressive lesion sitting within the humerus. I would probably put my bets on something like fibrous dysplasia, given the ground glass appearance of this as well. So the patient will probably need to go to the orthopods. They'll need to do a little bit more work on this as well, because it's not just a straightforward fracture. They may need to do some packing, curettage, and all that kind of thing of this particular lesion. Maybe even put an intermedullary nail if, depending on how bad they think this could be. Right. So we have stormed through quite a few cases, and I've kept you occupied, hopefully, for a good time. And yes, thank you as well. You're saying thanks, but thank you for helping me do this by giving me a few good cases for us to talk through. I'm going to stop my share. So for those of you that don't know, Collective Minds is a really great platform. A place that I work very closely with. I do a few videos with them. I run my own courses through them. They've actually are now supporting a lot of big courses. They actually had a course in Brazil where they had 3,000 delegates, 32 lectures all happening at the same time. And so there's quite a formidable platform that they put together. And for you yourselves, it's quite a good platform to be interacting with me and various other experts up and down, not the country, the world. And I've certainly learned a lot from you guys, interact with me, and hopefully you guys are learning a fair bit from me as well. So that's it from me. I'm going to hand over to, well, it looks like Sadhu might be freezing up. Sadhu, do you want to take over, or do you want me to finish off?
Can you hear me, Imran?
Yeah, I can hear you.
Yeah, perfect. Great. Thank you so much for this amazing lecture or seminar, like we always do. So if you have any remaining questions, or if you want to go over some cases, or you have any questions, make sure you remember that you can comment on the cases as well. So what's going to happen now is that we're gonna end this this webinar, but I'm going to send out CPD points to you who have joined. Okay, perfect. Yeah. There's a lot of you who actually came to us. So we were at UKIO this week. A lot of people show a lot of interest in the webinars, and it was really nice talking to you guys who came to the booth. So, well, it doesn't look like we have many more questions. And the collection, I sent it earlier in the chat, so just go into the collection and you can review the cases in your own time. You can, comment on Imran, and if you want Imran to look at some of your cases, just add him on the platform so you can see them. So it might be displayed for the next webinar. I know this guy from Mexico, Winston Wong. I think he's from Mexico or something like that. Last time I checked. So he actually added Imran. So it was. We took a couple of cases for him. But with that being said, thank you once again, Imran. Really, really good webinar. And thank you, Winston Wong, for supporting with a couple of cases. It was we are very, very appreciative of that. But I'm gonna send you a feedback survey. So feel free to answer that one, and also with a CPD point, because you joined for a 1-hour lecture. And with that being said, I wish you have a continuous good day, and I will see you on the next webinar. Okay, bye now.